Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Chairman and Co-Chairman, and thank you very much for the organizing and scientific committee to give me the chance to present my presentation. Actually, Dr. Khalid gave me a good introduction to my presentation, where majority of cases of chronic diarrhea are congenital chloride diarrhea. So probably in our community, or maybe in our society, does not take great attention to congenital chloride diarrhea, in spite that it is the major causes of chronic diarrhea. So my presentation will including genetic background, pathophysiology, clinical presentation, diagnosis and treatment, and we did just a retrospective cohort review of our cases. We have 29 cases over 20 years time. Dr. Khalid said here they have 56 cases of congenital chloride diarrhea in National Guard in Riyadh. So I expect a lot of my colleagues, they have so many cases, and we have colleagues from Kuwait where also they have a good number of cases. So, but because probably we are lacking of registry, so we did not register all the cases of congenital chloride diarrhea. So congenital chloride diarrhea is autosomal recessive condition, and the first case were detected in 1945 in Finland, and we have different indices in these incidents and prevalence of cases, where it's estimated to be 30 to 40,000 in Finland, and maybe around 40 to 50,000 in Poland, and in Kuwait it was 1 in 3,500. And we estimated our incidence of cases in Jeddah Military Hospital, 1 in 4 to 5,500. So this is what I said. Majority of cases are from Finland, Poland, Kuwait, and Saudi Arabia. But I'm sure with my personal contact that I found most of my colleagues in different cities in Saudi Arabia, we have so many cases of congenital chloride diarrhea. So it is a time really to have a registration for these cases. And I think in the future we're going to be a pioneer in this topic. So it is an autosomal recessive disorders, and the mutation in the gene of SLC26A3. And so far, we have 55 gene mutation, and this has been just recently published from south of Korea, where every year, you see a new gene mutation of CCD. It's usually in chromosome number 7, encoding apical epithelial of chloride bicarbonate exchanger. So far, no existent phenotype difference. And there are so a bit close mutation like cystic fibrosis or SLC26A2 and chondroplasia and Pendra syndrome are quite close to this gene mutation of CCD. As I said, the mutation is in a solute of carrier of family 26 member of SLC26 gene, which is actually leading to disruption of epithelial chloride by carb transport in the ileum and colon. And there are so many gene way of mutation in this protein, including single nucleotide substitution, missense, nessense, splice time mutation, or minor deletion or major deletion. So this is the pathophysiology. As I said, is mediated transport, the surface of epithelium of the ileum and colon, and actually this leads to intestinal absorption and secretion of chloride, of bicarb. So in addition to that, there is a defect of sodium and H transport exchange, leading to intestinal loss of sodium chloride and fluids. At the same time, is very watery, chloride-rich diarrhea, leading to decreased chloride, sodium, and potassium, and alkalosis. And these actually, because of these dehydration and electrolyte disturbances, will lead to activation of renin-angiotensin system, hyperaldosteronism, leading to sodium reabsorption in distal colon and distal kidney tubules. So how congenital chloride diarrhea present? Usually present in intrauterine, neonatal, late presentation, and extraintestinal presentation. In utero, there's in utero diarrhea with distended bowel, loops, and polyhydramnios. And now it's very easy for all of our colleagues of obstetrician when they do ultrasound and they found distended bowel, loop, polyhydramnios, especially if there is an index case in the family, this goes with congenital chloride diarrhea. So neonatally, when they born, majority of them, they born prematurely and low birth weight with no meconium. And sometimes maybe confused for the nurses as this is a stool or urine. It's very urine-like. And significant abdominal distension, and sometimes lead to dehydration, jaundice, and electrolyte disturbance neonatally. So this, you can see this massive distended abdomen, neonate, and there are late presentation where sometimes, if missed cases, they can be presented as a chronic diarrhea or failure to thrive, and sometimes maybe pseudobarter syndrome with hypokalemic, hypochloremic metabolic alkalosis, or sometimes they may present it with complication like renal. They may have ranging from echogenicity of the kidneys up to end-stage renal diseases where there are cases reported. And also they may have also CNS, some of cases that may be associated with epilepsy and growth failure. So extraintestinal, they may sometimes have epilepsy, male subfertility, hyperuricemic gout, increased sweat chloride test, stool incontinence, stool rectal prolapse, and excoriation, hernia, psychological, and family trauma, and so many questions of is it associated with malignancy or not. So to diagnose congenital chloride diarrhea, if you have an index case, it's very easy. You suspect cases, especially if there is some findings in antenatal ultrasound or the baby born with distended abdomen. Fetal, of course, ultrasound, if you check stool chloride, usually is very high stool chloride, and either there is non-predictable or very low urine chloride, and you may have typical findings of stool electrolytes with hypokalemia, hyponatremia, and metabolic alkalosis. If you check the serum renin and aldosterone, obviously will be so high, and of course, you confirm by gene test and you do ultrasound for any changes in renal or maybe associated renal complications. In long-term follow-up, you have to make sure that looking for growth and development for monitoring of serum electrolytes, renal ultrasound, renal chloride, which is probably a good indicator to know if your patient management is okay or not. If the patient is present with epilepsy, you may do EEG and similar analysis. They can have actually a quite abnormal or distorted sperm. And of course, genetic counseling was confirmed by gene. And some of them actually, they may have affect the brain and actually leading to psychomotor retardation. And maybe probably you need to do IQ testing if there is especially poor school performance. And you have to manage the complications and association associated with CCD. So management, usually very important to treat acute dehydration, treat electrolyte disturbance, salt replacement therapy, some trial of oral medications, and if there is any associated complication, you need to treat complications, and you have to have a maintenance and follow-up care because this is a lifelong secretory chronic diarrhea. So simple thing, I'm not going to discuss in detail the treatment, but when they need salt therapy in the first 2 or 3 years of life, they may need more sodium than potassium with ratio of 0.7 sodium chloride and 0.3 of potassium chloride. When the baby or the child grow up, reaching to 3 or 4 years of life, they need probably more potassium than chloride with ratio of 1.9 of potassium chloride and 1.8 of sodium chloride. And these are how, of course, all of you know how to manage the acute diarrhea. So there are so many oral medication has been tried for CCD, including proton pump inhibitors, and they found this decreased the volume and stool frequency and inhibition of gastric chloride secretion and decrease unabsorbed chloride in the stool. And it's been published that with just very either 1 or 2 cases where actually they may respond with decreased stool output and probably improve the stool incontinence. Oral butyrate, this is a short chain fatty acid, will actually prevent severe dehydration and stimulate intestinal water and ion absorption by activation of chloride, butyrate, and sodium exchange. And also it has some effects on hormonal and neural mechanism. Cholestyramine is not widely used and is not usually recommended to be used, but actually it reduces diarrhea and soiling, and it has some temporary effect, but we have to keep in mind the side effects of cholestyramine, and it is bile acid binder. Captopril, there is a case report in a child who was having underlying cardiac disease, and the patient at the same time diagnosed to have congenital chloride diarrhea, and the patient actually improved in stool frequency and also in stool incontinence. And this is work again through the chloride channel. So we did a retrospective cohort review of our patient, and we found the male actually more than female, and most of cases, actually majority, 28 out of 29 are Saudis and 1 only Sudani. Majority of cases are male, and this is the age at diagnosis. You can see some cases actually 13% diagnosed after 1 year of age, and during the first 20%, and majority actually at birth. So this is gestational age at diagnosis. You see there are almost 50% of preterm and full term of 46%, and extreme premature 8%. And this is antenatal ultrasound, probably not done in 13%, but all cases almost we did, almost in 86% we did ultrasound antenatally. So this is polyhydramnios. Majority of cases, almost up to 60%, we have polyhydramnios, and 27% we didn't know, and 13% where they have no polyhydramnios. This is the genetic mutation. We did almost for 15 cases, and we found SLC26A3 in 15 patients. For interesting, we have combination of two other gene mutation, SLC26A3 and M4770V. And we have some cases with combination of both, and some cases we do not do gene mutation. For interesting, this is the last SLC4A4. Actually, this being managed by a pediatric nephrologist as diagnosed as Bartter syndrome, but actually at the same time the patient is having chronic diarrhea and very high stool chloride. So this is a case of congenital chloride or Bartter, where there is a part of it of Bartter and part of it of congenital chloride diarrhea. So this is a family history. We have only 27% where they have positive family history, and 73% we have no family history of congenital chloride diarrhea. But actually, majority of my cases I have from certain tribe. So this is not a big surprise because of high consanguineous marriage in our community. This is urine chloride, where they have it during the diagnosis and follow-up. And we have less than 30% in 55% of cases, and more than 30 in 40%. Abdominal distension at birth, we found only on almost 1/3 of patients where they have abdominal distension, and the other they don't have abdominal distension at birth. This is the serum renin. We have, most of cases actually we have high serum renin and angiotensin and aldosterone at diagnosis. Again, this is the serum chloride. We have cases of, usually most of them actually, they have serum chloride, almost half of them between 90 to 110, and some of them also they have very low chloride. The serum again is applied to the serum sodium, where actually we found almost 60% they have almost normal serum sodium at time of diagnosis, and just only we have the rest less than 130 of sodium. Again, fecal chloride, most of cases actually we have very high serum fecal chloride, and is quite high for majority of our patients to have high fecal chloride. This is very specific test for diagnosis of CCD. Serum bicarbonate, majority of them we have actually normal between 22 to 29, and the rest we have high bicarb. Again, this is the serum potassium. Almost 50% of our cases we have almost normal serum potassium, while others we have low potassium level. So probably this slide and the other slide are the most important thing of my presentation. So as I told you, majority of cases I have is actually in one gene mutation. We have 4 cases with M47V. Some of them may be associated with SLC, 26A3 in 2 cases, and 2 cases they have just only pure M470V. For interesting, we have a twin, which one of them have SLC 26A3 and the other one have M47V. So that's good. I'm really sharing with you your experience in your institute or hospitals. Do you have this gene mutation? Because this M47V gene, actually, they usually presented with cyanopulmonary disorders and cystic fibrosis-like. And our pulmonologists, they treat them as cystic fibrosis. But why some of these patients, actually, they present with just pure GI with diarrhea, and some of them, they just only presented with pure respiratory symptoms. I don't know if you have different ways of gene mutation of this homozygous gene mutation. So this is for my interesting. And if you just follow up I follow up for over 20 years. Okay, 20 years, and these most of cases where they have complications or problem as a long term, most of them because of late diagnosis. I did not find any one of them they have any complications if diagnosed in early life and started treatment in early life and you do proper follow-up in the outpatient department. So for interesting, one of our cases, they have B-cell abdominal lymphoma, and this patient required huge doses of salt replacement. So probably to my knowledge, this is the first case where associated with malignancy with congenital chloride diarrhea. And other patient where he was diagnosed by adult nephrologist to have Bartter syndrome, and he came, just brought his sister to my clinic, and he told me, no, I have chronic diarrhea. So when I check his gene, actually he's having the same gene his sister is having. 2 cases we have for follow-up with epilepsy. So this is another thing you have to keep it in mind. Is it not related to congenital chloride diarrhea, or is it because of quiet disturbance of electrolytes and fluid disturbance, and that lead to some sort of brain damage and epilepsy? So, and one of my patients where actually I could not give oral, so I actually convinced the patient to have nasogastric tube feeding for a few months till the patient start to adapt and tolerate oral replacement therapy. So some of them actually, they may be associated with other complication or maybe other association like hernias or spermatocele or something like this. So actually, in my conclusion, actually, this is a common disease in our community. And I think it is a time for all of us to start registering all these cases and to share the same experience. And I think it's very good if we have good collaboration study for this very common condition actually we face in our community. Thank you very much.